welcome our next two guests. I'm joined by Dr. Courtney Genge, who's a program advisor for the National Research Council of Canada, and you're coming to us live from Canada.
From Canada, yes.
We had Laura from Canada earlier, but she's in Newcastle.
Well, I made the hop back over the pond.
So we have people from how many countries? So we've had somebody from Australia, we've had Sweden, we've had England, we've got Scotland later, Canada, and I've got somebody from the US at 6:30. So we've got, is that 6 countries? Let's say 6 countries represented. So it's amazing. Thank you very much for giving me your time. And I also have Dr. Emily Oliver, who finished her PhD last year and is now a consultant Admiral nurse for Dementia UK, which we haven't talked about enough today. But Dementia UK, of course, are also an amazing charity that fund Admiral nurses up and down the country who are helping people with dementia all the time. Actually, well, let's come to you first, Emily. Before we talk about your work, can you tell us about Dementia UK, putting you on the spot somewhat? I'm sure you know what dementia, because it's not a charity I work with a great deal. So can you tell us a bit more about Dementia UK?
Yeah, of course. That is on the spot. I hadn't prepared that, so thanks, Adam. No, that's absolutely fine. So Dementia UK are a national charity. They were set up by the Levi family, who looked after their dad, who had dementia. So Joseph Levy, he was their dad, and he loved sailing. So he was called Admiral Joe, and that's why we have Admiral nurses. So I always like to start off with that. So we support nurses in a range of settings. So hospices, hospitals, community services, prisons we're branching out to. We have learning disability nurses, and they support families living with dementia. And that's sort of from peri-diagnosis through to end of life and into bereavement as well. And we've also got our national helpline that is, sort of funded by donations. And that's there for anybody who is looking for support with dementia, whether that be people with dementia themselves, whether that be families, whether that be professionals who need some more support. So that's staffed by dementia specialist Admiral nurses.
So that's great. So I'm not particularly raising funding for them today, but it's an amazing cause. So also, please do head over to Dementia UK, have a look at their work. Admiral nurses do an amazing job. And Emily herself being, so you are an Admiral nurse, but you play a slightly different role there. Could you tell us what you do? Let's talk about your work.
So my role, there's 8 of us in my team. So we're consultant Admiral nurses, and our role is to support new services with the first 6 to 9 months up to a year. So when new nurses come into post, we help them sort out the sort of clinical logistics of the service. And we also, do dip into research in our roles. It's not predominantly our role, but we do sit on advisory panels. We do write papers about Admiral nursing. And we also sort of do media inquiries, things like that.
So that's quite a tricky role to set up. I mean, do you also then have to do some of we were talking earlier about how hard it is to keep on top of the latest research and the latest thought processes on how to care most effectively. Is that part of your job as well, to keep on top of that and share that?
So we do have sort of a designated professional and practice development team. So similarly, again, there's 8 of the professional and practice development team, and they work really hard, tirelessly hard, to support the nurses with the latest evidence-based practice. They put on webinars for the nurses. They provide professional development afternoons, clinical supervision. So their role is to support the nurses to ensure that they're at the top of their game, up to date with the latest evidence base. So I can't take credit for that, I'm afraid.
No, but so tell me, and this will segue me nicely to talk to Courtney in a moment, which is, how do Admiral nurses fit in with the NHS?
Yeah, so they don't just work in NHS organisations, they work across sort of private, public, voluntary sector. But they provide what we call tier 3 level support. So you've got the tier 1, which is sort of advice and guidance, tier 2, which is bespoke, so community psychiatric nurses, and then tier 3 services, which is where Admiral nurses sit. So they provide support to families who really need that or going through that complexity. And then what they do is they support nurses or healthcare professionals in those other 2, so tier 2 and tier 1. So it's a whole systems approach, but the direct family work is at that tier 3. support.
So just thinking about the pathway and access then. So somebody comes through, they go to their GP, they then go on to a memory clinic, they may or may not get a timely diagnosis, as we've talked about, or an accurate one, as we've talked about various points today. And then, so where then does the Admiral nurse sitting, I mean, what practically would an Admiral nurse do with a family? Are we talking about now to put in place a power of attorneys, or are you talking about really going and helping people get out of bed? I mean,
yeah, so it's really dependent on where the nurse sits and sort of what the support needed is in that area. So for Courtney, I know that your work is based in acute hospitals, for example, similar to mine. So an Admiral nurse in an acute hospital potentially could work across every division. They might focus on acute accident and emergency, they might focus on the other end, so they might focus on discharge, and they will get a referral either from the people with dementia themselves or the family themselves, or from professionals. And if they just need that higher level of support, it could be they do absolutely anything. So it could be they need support with discharge, or it could be that they need a package of care. So it's sort of that case coordination role. So they bring all the services together to provide that support.
And they can signpost people back. And Courtney, I'm going to bring you in now, because I think that I was working up to this. So your research was looking at acute hospitals. Tell us about your research.
Yeah, so my research was focused specifically on the emergency department, that transition from being in the community to potentially needing care in the inpatient setting. And it's a fantastic segue, because you jumped right to one of my conclusions, which is you need Admiral nurses in the emergency department.
Well, I was working up to this, because I was going to say our Admiral nurses in that place. Go.
Yeah, so my work was focused specifically on that emergency department setting, and it's sort of the emergency department is usually thought of as a place where people sort of transit. It's not a place where you spend a lot of time, especially with the 4-hour targets in the UK. Unfortunately, people with dementia do tend to spend a longer time in the emergency department. And when they're in the emergency department, they're at a higher risk for accidental injuries, for deterioration, and also for delirium, which then complicates their discharge and their ability to return back to the community. So my research was really trying to identify some of the patient characteristics and patient profiles, and also the staff and environmental context that sort of led to those poor outcomes, with a view to identifying opportunities to improve the quality and safety of care. And spoiler alert, one of them is having highly trained Admiral nurses or other, dementia specialist nurses based in the emergency department, because they have this unique ability to organize care in the community and to identify, the needs of that patient and the family, and then get them back into the community without needing admission to the hospital, which is an ideal scenario in most cases.
And I'm guessing Admiral nurses aren't sat in A&E waiting, but if they end up with a situation, is that where nurses can find themselves?
In all the hospitals that I worked in, there wasn't an Admiral nurse working in the emergency department, but they liaised very closely with the frailty team that was based in the emergency department. And that really close connection, either to the Admiral nurse based in the community or in the inpatient acute care setting, really facilitated, admissions avoidance. So that close working relationship between the emergency department staff and the care in the community, whether that's through Admiral nurses or the frailty team, was absolutely essential.
Yeah, helping navigate that system and move them through, because A&E, because I previously worked on MRSA and things like that as well, and you just know that people are vulnerable to pick up infections and things as well, and so not having them there if they can't. And Admiral nurses have a great role to play in moving people through, so they're not in the same place. So what were the other findings of your work, Courtney?
So I was able to identify.
It was just you, right?
No, I always do that. It's team thinking.
Take credit for it. I
found that there was a particular profile of patients that were a higher risk for experiencing a poor outcome of care. And that included people actually who had more moderate dementia and who were mobile. So, typically we would conceptualize people with more severe dementia as being higher risk, and they are for things like delirium, but the most high risk patients were the ones who were disoriented and mobile. And they were most likely to end up with an accidental injury in the emergency department.
Oh,
We also,
really?
similar to what Professor Claire was saying, the staff just didn't feel like they had the right training to provide holistic care, and that in a lot of cases the organizational culture, the sort of the way things are done in the emergency department, it doesn't support the holistic care that people with dementia really need. So came up with sort of a framework and a model of what dementia-friendly emergency care might look like. And that has the 5 pillars of care in the community, enhanced clinical protocols that are geriatric specific, an organizational culture that supports safety first thinking, better education and training, and involvement, changing up the physical environment just to make it a more safe and more comfortable environment. I mean, nobody likes hospital trolleys, especially not for hours on end if you're not comfortable and you can't understand why you have to stay there. So that's sort of high level. There's opportunities for improvement in all 5 of those areas.
And I'm right in thinking, so Health Education England play a role in providing that kind of all-round generic dementia training, right, for all staff. Is there an expectation, I think, since the old Prime Minister's challenge on dementia, that everybody should have, when you talked about tier 1 and tier, I don't know if it's the same tier system, Emily, but everybody had to have tier 1, right? Even to work in the NHS, you had to have tier 1. What kind of tier training do people in emergency departments have? Is this something they volunteer for? Is there a requirement that they must have done more?
So everyone is required to have tier 1 training, and the overwhelming response from A&E staff was that wasn't enough, that they were interacting with people with dementia who were often in crisis, either physically or in some sort of a mental health crisis, and the tier 1 awareness was not sufficient to address the needs of that population in that setting, and they were desperate for more hands-on training. And in fact, they were quite specific that they wanted simulation-based training, they wanted preceptorship and mentorship programs, especially for the nursing staff, where they could learn from more experienced nurses about effective ways to de-escalate behaviors and, achieve the outcome that they're looking for in many cases, actually conducting diagnostic tests to understand what is going on, which isn't possible unless they have that training.
So finding time to do and what are the other, Emily, I don't know if you've looked at this, what are the other, what's the difference between tier 1 training? How far do the tiers go?
Yeah, sorry, Courtney, go on, you can.
No, you go ahead.
Emily on this.
It's like the basic, and then as it goes up, it gets more complex. So, tier 2, you might be looking at sort of bespoke management of dementia or diagnosis, and then tier 3 would be, how to de-escalate managing behavior. Actually, Courtney, what you said, those the things that the A&E staff is at sort of tier 3, which is, like you said, it's unlikely that the nurses would be getting that as a standard. It's usually when an Admiral nurse or a dementia specialist nurse is the catalyst to put on those training days, and that isn't always possible. And another thing I found interesting from what your research said, so my research was quite similar actually, so I looked at medicine for older persons wards and nursing staff capacity for good care there. And what I've heard from the nurses was that you get a lot of training because those wards meant to be more specific for that patient population, but actually transferring what you learn in the training room back to the wards is one of the hardest things. And that was what came from my research, was that actually, even if you had the best training in the world, the culture in which the organization sits doesn't allow you to practice in that way, which is very interesting.
Well, that's tricky. Obviously there's often this kind of comment that if you don't get to use training very often, it won't be helpful. But I get the feeling in this instance that there are so many people living with dementia, going through acute care pathways or on wards, that any training they get, they're definitely going to get an opportunity to make use of. So what did your PhD research find, Emily, in the end? Or tell us about your PhD project. You do that for a minute while I have a drink.
Oh,
While I make another coffee. I'm going to turn my camera off for a second while you tell us about your PhD project.
Okay. Yeah, so as I said, my research was looking at nursing staff capacity for relationship-centred care on medicine for older persons wards. So as Courtney was saying, there's a real understanding that dementia care in hospitals isn't as good as it can be. There's a lot more that needs to be done. But there wasn't always an understanding of why that was, sort of what was the catalyst for that. And especially on medicine for older persons ward, because there was this expectation that actually that's your bread and butter. You should be, providing the highest level of dementia care, because actually 1 in 4 or 1 in 3 beds are occupied by somebody with dementia. So I did some observations and interviews with nursing staff, and a lot of what I was saying, really, there's like this pull between what the patient needs and what the organisation needs, and the pull of the organisation is always stronger than the pull of the patient. So actually nursing staff are in between a rock and a hard place, really. And one of the things that really shone through in my research is that actually we talk about relationship-centred care as the gold standard for dementia care, but nobody can really articulate what that looks like. It's not a tangible thing. So when we put things in place in hospitals which are target driven and measured, relationship-centred care isn't one of those things. So nursing staff will always do the things that are like visible to the organisation, which are, pressure ulcer prevention. If somebody's got a pressure ulcer, that can be recorded. If somebody got sepsis, that can be recorded. If somebody's blood pressure wasn't done, because again, you can record that. You can't record whether someone delivered relationship-centred care. So within a hospital organisation where the priorities are the things that they measure, of course, nursing staff are going to find it difficult to do the things that aren't measured when they're already struggling to do the things that are. So a lot of things came out of my research. One of the things is that actually we can't implement interventions without looking at the organisational culture. We can't implement interventions that don't look at what the nursing staff routine is. So there's no point implementing an intervention that requires the nursing staff to do additional things when they're already struggling to do the things that they're doing. And a lot of it came out about team dynamics as well. So there's a real sort of cultural difficulty in healthcare, because the medical nursing hierarchy has diminished, and now the hierarchy's in the nursing teams themselves. So we've got nurses that are now turned into managers, we've got healthcare support workers that are as trained as nurses. So there's almost a bit of complication about whose role is who, which also causes some difficulties in providing good care. So I don't know, did you look at nursing staffing in your work, Courtney? Yeah,
definitely. It came up quite a bit in the instances where people were talking about where safety incidents, fairly serious safety incidences had occurred. There was often a lack of clarity about whose responsibility it was in that particular moment, or when there was different staffing ratios in the A&E, or there was tensions between the different levels of nursing. That was often when you saw people falling out of beds, or medication errors, or people not being fed for 12 hours because there was no clarity about whose responsibility that was at that time in the shift, which obviously it has catastrophic impacts all the way through a hospital stay if you've not had anything to eat for 12 hours when you're 90.
Mine was it wasn't a negative thing. Like the nurses and the healthcare support workers were trying to help each other. Delivering the chocolates. We're trying to help each other, but in doing so we're sometimes rushing through their tasks with the patient to help their team members. So it was a positive thing, but it had negative consequences.
Yeah, I think with that one of the hospitals that I was working in was having a really hard time with their A&E, and it was sort of under a lot of supervision from regulatory bodies and everything. And there was this feeling at the time that there was a lot of criticism and not very much understanding of the context of the work. And so if you were ever to step outside of your role to try and do something extra for a patient that wasn't technically designated as your own, that you could be criticized for that. And there it became this sort of culture of, you know, don't touch anybody else's patients, don't work anywhere other than what you're supposed to do, because even if you're trying to help, you'll get criticized. And that culture was extraordinarily challenging, and it was really causing a lot of distress for the staff because they felt like they were having to disregard their natural instinct to care.
That's disappointing, isn't it? That's where you would hope that regulatory bodies would have the flexibility to understand the differences there. So I'm going to ask this question. So having you both finished your PhDs last year? No, Courtney, yours was longer than that.
2018, October.
2018.
Yeah.
So has your work gone on? Obviously, I know you've both gone on to continue in dementia research or to continue in dementia in your own way. How hard is it to take what you learn, which is these really valuable, useful lessons from your PhD project, to then give them to somebody to act upon? Were you both funded by Alzheimer's Research, Alzheimer's Society or NIHR or?
I think
NIHR.
NIHR.
I was Alzheimer's Society.
You are Alzheimer's Society. So the funders have this, they want you to give the results back, right? I mean, that's part of the funders are getting good at that. But
yes, it's hard for me because I fled the country. I submitted and then I left, 3 days later. And I'll be honest, it's been a struggle to kind of get reestablished in Canada. There hasn't been very much uptake. I'm still working on that. I think it's a real shame that it hasn't gone further. There was a lot of enthusiasm about this idea of working towards dementia-friendly emergency departments right at the time that I submitted, and it's kind of faded a bit. And
everything else, COVID has realised that the world has become that much smaller now, hasn't it? I think, I've got a colleague who's about to be working from an entirely different country because it needs must. And so I think being able to continue your work and spread it in that way, if you've got the connection, should be there. And we do still have a little bit of time for questions. If anybody would like to post a question, you can use that. Use the Q&A button in Zoom, or you can post in the comments box of YouTube, and I'll put your questions to you. So thinking you've just got a new job as well, Courtney.
Yes.
In the time. So how is because your new job is still related to aging. What's your new?
Yeah, so I'm sort of shifting gears into policy-based work. So I'm working for the National Research Council of Canada. They are starting a challenge program, which is a 7-year program of sort of concentrated work in a particular area. So the work is on aging in place. So for the next 7 years, we're going to be, working with the best of technology and industry and academia to really push forward advances in technology and also in society that will enable people to age in place. So I'm one of their program advisors. And I'll be helping to sort of steer what that looks like and help to bring in, the perspectives of older adults and hopefully keep dementia right at the very forefront. Just providing some alternatives to nursing care and trying to create a system where people are able to stay at home longer.
That's brilliant. That sounds an exciting new job. Oh, we did just have a question come in. Chris says, how do researchers engage with Admiral nurses for expert advice?
Yeah, great question. So my email is on there. So please do send me an email. If not, we've got a research and publication team. So all the information is on our website. We would be absolutely delighted to sit on any research panels. And we also do professional development afternoons, which we have had researchers come and talk and sort of, ask for advice. So please do get in touch.
Fantastic. Thank you very much. The arrival of our next guests marks the end of this session at 6 o'clock. Thank you very much, Dr. Courtney Genge, for finding time to join us all the way from Canada, and Emily as well. Dr. Emily Oliver, for joining us both. Fantastic work, and please do continue to do what you do. And thank you very much again for joining.